Good morning, everybody. I'm delighted to be here today to have the opportunity to talk about the assessment of vitamin B12 levels. So what I mean by this title is how do we establish whether somebody is vitamin B12 deficient or whether they are B12 replete. Now we're going to go into this story very slowly and we're going to cover all of the basics first so that we make sure all of us understand some of the complexities that we will see later. So vitamin B12 is unusual for several reasons. One of the reasons is the only vitamin that can only be made by certain bacteria, the prokaryotic bacteria. Now, making B12 from scratch, the biosynthesis, uses a lot of energy. It requires about 30 different enzyme catalyzed reactions. And actually, most organisms try not to make the vitamin themselves. They try to get it from other sources. Or they avoid a dependency on B12 altogether. The plants, for example, have no metabolic requirement for vitamin B12. They have no mechanism for its production, and they have no mechanism for its storage. We, however, as humans, have evolved a dependency on dietary sources of B12 to support our health. Another reason B12 is unusual is it's the largest of the 13 vitamins and has the most complicated structure. It's the only vitamin that contains a metal ion, so the cobalt atom. And this atom is absolutely crucial for the structure and function of the vitamin. Now, the cobalt atom is held in place by 6 coordination sites. Now, the metabolically active form, is the 6th coordination site that is occupied by a methyl group, and that gives us a form of B12 called methylcobalamin, or alternatively, it may be occupied by a 5-deoxyadenylyl group. And we refer to this form of the vitamin as 5-deoxyadenyl-cobalamin. And we have 2 enzymes in our body that require B12 to work. So one of them is methionine synthase, and that requires the methylcobalamin form of B12. And the other one is the methylmalonyl coenzyme A mutase, and that requires the 5-deoxyadenyl-cobalamin form of B12. So that's probably enough chemistry for us this morning. So because plants can't make or store B12, our requirement for B12 can only come from food of animal origin, because we can't make vitamin B12s ourselves. Now, we don't need much B12 each day to have a healthy life. In the USA, the recommendation is 2.5 micrograms a day. In the UK, it's slightly lower at 1.5 micrograms a day. And for most people, our dietary intake of the vitamin exceeds our metabolic requirement. And this means that over time, we start to accumulate some stores of between 1 and 5 milligrams. Now, most Western diets contain 4 to 6 micrograms of B12. But it's important to remember, just because you're consuming food with a vitamin in it, it doesn't necessarily mean that you're able to absorb all of it. So in the case of B12, a healthy person will only be able to absorb between 1 to 5 micrograms of what you eat. People that have problems absorbing the vitamin may not absorb any at all. Another interesting fact is that the absorption of B12 is limited when you have a single meal, and it can't exceed around 1.5 to 2.5 micrograms. And that's because you have receptors in the ileum that catch the B12. And once those receptors have all been used up, you have to wait 4 to 6 hours for the receptors to become available again. So there are many reasons why any one of us on this call could become B12 deficient. These reasons include you may have chosen to consume a restricted diet. For example, you may be a vegetarian or a vegan who only eats a plant-based diet. If this is the case, you won't be getting enough B12 from the diet to meet your needs. You may have a problem absorbing B12. For example, there's an autoimmune disease called pernicious anemia, which prevents you from absorbing the vitamin from food. Also, all of us, once we get past the age of 40 or so, will start to have diminished capability of absorbing B12. You may have Crohn's disease that impedes B12 absorption. And there are many other factors, and these include pregnancy. During pregnancy, a woman has a higher requirement for B12, or it may be because of use of substances like nitrous oxide, also known as laughing gas. And this also leads to B12 deficiency. We'll mention pregnancy and nitrous oxide a little bit later in this short talk. But it's surprisingly difficult for a medic to diagnose B12 deficiency. And one of the reasons for this is that the clinical consequences are often quite vague. They are often quite non-specific. One misnomer is that all B12 deficient patients would have anemia. This isn't the case. At least 20% of people who are B12 deficient don't have anemia. Instead of anemia, they may have cognitive decline. They may have neurological problems because of B12 deficiency. But diagnosing B12 deficiency quickly is really important. This means that treatment can start and it can protect against megaloblastic anemia, neuropathy, and neuropsychiatric changes. Now, importantly, some of these changes, neuropathy, for example, in some cases become irreversible. So the later you diagnose the deficiency, the more likely the likelihood is that you could have permanent problems. So we are talking about one vitamin today. So that one vitamin is B12. And we are talking about two enzymes that are B12 dependent in our bodies. But if this vitamin isn't available, it can lead to a whole range of problems. And I've identified some and listed some here. And all of us will express a B12 deficient state in a slightly different way. So it's quite a complex picture. Deficiency is common. I happen to work in the United Kingdom, in the UK, and we see that about 5% of people over the age of 65 are deficient. The incidence of deficiency increases as age increases. So by the time you get to about 75, it's about 10% of people. Now, I've already said that it can be difficult for a medic to identify a deficient case. Actually, identifying it in the laboratory is also no easy task. And we will talk about why that is in a moment. But it has been long known that many patients, even with pernicious anemia, which can cause severe B12 deficiency, can wait several years to get a diagnosis. But when should you test someone's B12 state? When should you test their B12 level? Well, B12 deficiency is commonly diagnosed and treated in primary care when a patient presents with quite non-specific complaints. This just could be tiredness, for example, and many factors can cause tiredness. Sometimes B12 deficiency is diagnosed by accident because of other investigations, or it may be targeted testing because the patient has a common symptom or a sign or a risk factor that means there's a higher chance of that patient B12 deficient. So this is an example of where B12 deficiency could be identified by accident. So you may do a full blood count and you may see in a blood film that there's unusual cells that are funny shape or they're too big. Now, what is important again to highlight is that not all B12 deficient patients will have macrocytosis. Not all B12 deficient patients can be picked up through a full blood count or through the analysis of a blood film. And even if they are picked up this way, we must remember that a hematological expression of a deficient state for B12 is a late indicator. We'd much rather detect deficiency before it gets to this stage. So now let's have a little bit of a focus on how the laboratories can help you reach a diagnosis of B12 deficiency. So you are probably at the moment thinking about the serum B12 test. It's one of the most common tests performed in any laboratory. In fact, laboratories have been performing the serum B12 test for about 75 years. But for some patients, the chances of reaching a correct diagnosis using serum B12 on its own is only marginally better than flipping a coin and saying heads or tails. This leads to a delayed diagnosis for the patient. It also can impact the wider healthcare system because of unnecessary multiple consultations or imaging or repeat laboratory tests. The consequences for the patient can be quite severe. It can mean that they are no longer able to work. If they are a young person, it may mean that they are unable to participate in full-time education. But the consequences of a B12 deficient state really are severe in some people. Now, laboratories have over the last 75 years developed methods that make performing the serum B12 test easier. So the very early assays from 1950 were microbiological assays. They were quite good, but they were very manual and took a lot of time. And then we have seen a progressive technology innovation to bring us the really rapid tests that we have today in most chemistry laboratories. Alongside this technology innovation, we've also seen a focus on quality. So now we are able to perform thousands of serum B12 tests in any laboratory every day at a cheap cost, very rapidly in a high quality environment. But like so many tests in our laboratories, have we spent sufficient time to actually scrutinize the utility of the serum B12 test itself? Well, I hope so, because many of us on this call will be doing a lot of them. In the National Health Service in England, some laboratories perform up to 120 serum B12 assays per thousand of population a year. But how many of those laboratories really understand what they are measuring? How many understand what the result is really telling us? How many people ordering the test understand the limitations of this serum B12 assay? So we measure the serum B12 level, we get a concentration, and interpreting the concentration is quite easy, isn't it? Because we have a reference interval. And if the concentration of serum B12 is below the lower limit of the reference interval, we come to the conclusion that that patient is B12 deficient. So I put a red dot on this simple graph here. If the result is within the reference range, then we say the patient is fine. We call that replete. And if they're a little bit high, and I've signified this here with the purple data points, then we say, okay, you're replete and there's nothing to worry about. It's very simple, isn't it? But what would happen if we sent an aliquot of the same sample to all of the laboratories in the United Kingdom to investigate my B12 state? Would I be confused? Well, I think I would be. So here is an example from an EQA scheme. So each dot here represents one laboratory or one analyzer. You can see along the bottom here where we have indicated the different method that has been used. So it's Abbott, Siemens, Roche, Beckman, all the commonly available platforms. And you will see if this was my sample, and these are genuine results here, Some labs would tell me that I'm deficient. This is the red. Some would tell me that I'm normal. One laboratory would tell me that I'm high, and some laboratories would tell me they're not sure, and that would be in yellow. So this is far from conclusive. It's confusing for the medic. It's confusing for the patient. But actually, even if these data points are all the same color, I would still have a lot of questions to ask, and this is why. When vitamins were discovered, the temptation was always to measure them in blood, plasma, serum, to estimate data. But it's only telling you how much of the vitamin is there. So this is a type of static biomarker. It tells us about abundance. It doesn't tell us anything at all about the function of those two enzymes I told you about at the beginning of this call. It only tells you how much of that vitamin is in serum. This is not ideal. The other challenge with serum B12 is you are measuring B12 that's bound to two different vitamin B12 binding proteins. Now, most B12 in your circulation binds to a protein called haptocorin. When the B12 binds, it's called holohaptocorin. So let's say around 80% of your B12 is bound to haptocorin. Only a minority fraction of B12 binds to the other protein, which is called transcobalamin. But it's this protein that is important because cells that require B12 to function properly only have receptors for B12 bound to transcobalamin, which is known as holotranscobalamin. So when you perform a serum B12 assay, you have no idea how much of that result is telling you about B12 and haptocorin and how much is telling you about B12 and transcobalamin. It's important to note that we have no idea what role haptocorin plays in terms of B12 status in humans. There is no evidence to support its B12 status. So most of what you're measuring is of no use metabolic. The other challenge I have with serum B12 is that nearly all laboratories use a single reference interval to interpret results from all of their patients. But we know now for the last few years that there is quite a difference depending on your ethnicity, on your gender, on your age. If you happen to be a black young patient having your result interpreted against a range derived from older people, is that correct? If you are a pregnant woman having your result interpreted against a reference interval determined from men, is that appropriate? It probably isn't. So when you look at all the different factors that have a negative impact on the performance of the serum B12 assay, we see that estimates are that the sensitivity of the assay, if you have a low cutoff, let's say 170 nanograms per litre, is about 35%. So this means that out of every 100 patients who are B12 deficient and have the serum B12 test, if that's your reference interval, only 35 of those will get the correct diagnosis. That means that nearly everybody you've told that they are deficient, the sensitivity is poor. So what we can do in this situation, you will know, is that we could increase the cutoff. So let's say we go for a high cutoff of 340 nanograms per litre. In that scenario, your sensitivity jumps to 85%, which means you're detecting the majority of people who are B12 deficient. But unfortunately, if you take this approach, the specificity of the assay drops dramatically down to 45. This means that in most cases, the people you are telling are deficient are absolutely not deficient and they don't need treatment. And let's remember, sometimes treatment for B12 deficiency is lifelong. So there are many reasons why you should think about the utility of the serum B12 assay and that you should use it carefully. And if you are going to use it, deliver it well. Think about your reference intervals, for example. The other fact is that there is very poor harmonization between the different methods for serum B12 between different manufacturers. Beckman, for example, will give you a lower result than the other manufacturers. It doesn't mean Beckman are wrong, it just means they're different from the other manufacturers. We need to see more effort in harmonization. There's also evidence of longitudinal variation in the performance of these assays. So I've given you quite a lot of bad news in this talk so far, but there's a lot of good news for laboratory markers of B12. And the good news is because we don't have to just use serum B12 to evaluate B12 status. Other options are available. So let's try and simplify this diagram here. So this is showing you something about 1-carbon metabolism. But we know now, having heard this talk, that we get vitamin B12 from our food. We know now that freshly absorbed B12 is bound to hollow transcobalamin, and it's hollow transcobalamin that delivers B12 to the enzymes that need it, methylcobalamin and adenosylcobalamin. Now, we also know if for any reason our intake of B12 containing food goes down, or if suddenly we don't absorb the B12, we will see a corresponding decrease quickly in a hollow transcobalamin. This means that less B12 will be delivered to our cell. And helpfully, the enzymes who no longer have enough B12 to function will start to work suboptimally, but they will send us out, if you like, a biochemical distress signal to say something's not right. So for methylcobalamin, it will tell us by us seeing a higher concentration of homocysteine. And for the adenosylcobalamin, we know that that enzyme is not working properly because we start to see an increase in methylmalonic acid, also known as MMA. So suddenly, we have some options here. We have the serum B12 test, which you now know reports some of holohapcorin and holotranscobalamin, or we can measure holotranscobalamin directly ourselves. All manufacturers make this test available now. When they sell this test, they don't sell you a test called holotranscobalamin. It's called active B12. So holotranscobalamin and active B12 are the same thing. Or you could choose to measure homocysteine, or you could choose to measure MMA. So we have in our diagnostic toolkit suddenly 4 options. So let's look at holotranscobalamin, active B12. So you're only measuring the form of B12 that can reach your cells. And direct comparison of serum B12 with active B12 tends to suggest that the active B12 test is moderately superior than the serum B12 test. But you still have that challenge in that if you want to have a high degree of sensitivity for that assay, you will have a correspondingly poor specificity. If you want to boost your specificity, you can't do that without reducing your sensitivity. So if I was to send aliquots of my sample to all the labs that do active B12, would I be confused or would I have a definitive answer? Well, I'd still be confused. If I had my active B12 measured in this exercise, some labs would tell me I'm deficient or low, some would say I'm normal, one would say I'm high, and some would say I'm indeterminate. So this is equally confusing. Now your eye may be drawn to the middle of this figure, where for the cobas assay, we have a cluster of green. So you may think that suddenly we have some certainty, but this isn't the case, because we know at that concentration of active B12, there would be a corresponding instance of a 25% of those samples would have an increase in MMA. And MMA, you will now know, is telling you that there is a functional deficiency in B12 at the tissue level. So the enzyme itself isn't receiving enough serum B12, isn't functioning properly, and we're starting to see an increase in MMA. So the likelihood of your patient having a high MMA concentration increases as your hollow transcobalamin concentration goes down. So how do we get around this unbreakable link between sensitivity and specificity for the serum B12 and active B12? Well, you can introduce an indeterminate range. And this is something my laboratory team have been doing since 2012 and is now part of the guidance in the UK from NICE. So here's an example cutoffs based on the NICE recommendations. So any result below 180 nanograms per litre, B12 is deficient, or 25 picomoles per litre active B12. But in this indeterminate range, what happens is that a second line test is recommended. And we will talk about that now. So if you want to use multiple biomarkers, you should configure your frontline test to have high sensitivity. And you do that to avoid missing deficient patients. And you want to select a biomarker that can be performed with high automation. It needs to be affordable, needs to be robust. So in this case, you could use serum B12 or you could use active B12 to screen all samples and then have an indeterminate range where you do a second line biomarker. And in this case, it could be homocysteine or it could be methylmalonic acid, MMA. And you can figure this to have some high specificity to guard against telling people who are replete that they are deficient incorrectly. Now, this approach is not suitable for pregnant women or after nitrous oxide exposure, and we'll come back to that later. So let's look at homocysteine. Now, we don't tend to recommend homocysteine as a second line test, and this is because there are other vitamins that impact on your homocysteine concentration, and that includes folate. Folate has a much bigger impact on your homocysteine concentration than B6. Than B12. B6 also has an impact, and B2 has a tiny impact. Homocysteine also goes up with age, and it also increases if you have poor renal function. So we won't spend too much time today about homocysteine. So a better, more specific biomarker to look at B12 status as a second line test is methylmalonic acid. Now, there is no gold standard laboratory test to evaluate B12 status, but the MMA test is the best performing out of the 4 that are routinely available. It's not perfect. There is still some dependency on your renal function and on your age, and there are certain single nucleotide polymorphisms that have an impact on your MMA concentration, but it is the consensus view that this is a proxy gold standard for the evaluation of B12 status. Now, demand for MMA has grown tremendously in the last few years, and this has been because in March last year, the National Institute of Clinical Care and Excellence published guidelines for best practice on diagnosing B12 status. And I was part of that committee, and the outcome from in the guidelines was that MMA is a recommended test. But there is a problem. And one of those problems is that at the moment, most laboratories who do MMA use a mass spectrometry-based assay. This can be relatively manual, can be expensive for some people, or laboratories don't have access to mass spectrometry themselves, or they can't get the workforce with the skills required to perform the test. In my own lab, MMA, we now get thousands of samples requested a month, and we have seen a 52% increase in the last 2 years. It is very hard to implement the guidelines because of the technology barriers. So we are working at the moment with our collaborators called William Oak, which came out of University of Cambridge, and they have now developed a plate-based assay using a novel synthetic enzyme. This assay should be available towards the end of next year and will be widely available, which will help more laboratories be able to perform the methylmalonic acid test. So, before I conclude today, I just wanted to touch on two, let's call them special cases where we need to be particularly careful when we are using laboratory tests to evaluate B12 status. Now, some of you will have heard of nitrous oxide. It is often used in hospitals for pain relief, but increasingly in some countries, it is also used and abused socially. So it's called laughing gas. Users get a short-term high and then return to normal quite quickly after a short period of euphoria. But long-term use has serious consequences. And this is because the nitrous oxide oxidizes the cobalt atom in the middle of the B12 structure from a 1+ to a 3+ valence state. Now, in the 3+ state, the enzyme methionine synthase is unable to use that configuration of B12. And this leads to an increase in homocysteine. Now, the other pathway, the other enzyme, is not affected so much because that requires the 2+, which is insensitive to nitrous oxide, although long-term exposure will eventually degrade the B12 and also increase MMA. So, if you need to evaluate B12 status in someone who's been abusing nitrous oxide, be careful to select the correct biomarker. And you should use, in this case, homocysteine, because the assays for serum B12 and active B12 are unable to differentiate between the different forms of B12 that have different valence states of the cobalt. You could have someone who's severely deficient, but their serum B12 and active B12 results will still come back as normal. So that can delay diagnosis. So that is something to think about. If you have ever seen these canisters disposed of in the street, and this is a picture from around London, these are young people using canisters, although they're using bigger and bigger canisters, and we are seeing more and more patients with B12 deficiency because of nitrous oxide abuse. The other special case we will talk about today is pregnancy. Throughout pregnancy, the woman has a higher requirement for B12, and the recommendations are that you should use active B12 as the initial test if you are screening a woman for B12 deficiency in pregnancy. This is because the serum B12 concentrations drop anyway during pregnancy, and this isn't necessarily linked to a decrease in B12 status. It is often linked to a decrease in haptocorin synthesis and hemodilution. So active B12 is a better performing test in these situations. If you want to perform a second-line test, so homocysteine or MMA, for a woman during pregnancy, don't wait for the result of the second-line test before treating. So in summary, evaluating B12 status is not simple. And if you are just using a single biomarker, this approach has limitations. Whatever diagnostic marker you're using, you should be careful to optimize it. Use the correct reference interval, use the correct biomarker. And that's because if you're measuring vitamin directly in blood, it may not necessarily reflect the status at the tissue level. As you've seen here today, combining biomarkers together can help mitigate some performance issues. So recommendations tend to suggest using serum B12 or active B12 as your frontline test, remembering that active B12 performs marginally better than serum B12, and then for a proportion of patients who are in an indeterminate range, also perform methylmalonic acid. But remember, even a really great biomarker like methylmalonic acid can be delivered poorly if you're not careful around reference intervals and standardisation and harmonisation of assays. Thank you very much for having me today. I've enjoyed speaking, and enjoy the rest of the Congress.